Distinguished professors and colleagues, welcome. Antipsychotic medication use in children and adolescents and the prevention of the subsequent resistance. But when I observed the literature, I really couldn't find much on this. Resistance has to do with psychological fear of the medication. This is what I observed, so this is what I based my speech on. Antipsychotic medications before the 90s, they were the typical neuroepileptics. After the 90s, our current topic, the atypical antipsychotics have come into use, the most important difference being serotonin dopamine blockage. Whereas before the 90s, they just did dopamine blockage, so they have more serotonergic blockage. So that's why they call it atypical. So briefly, the historical development shows that, as we all know this timeline. Antipsychotic prescriptions, of course, I don't know what's going on in Turkey, but in the USA, and after the year 2000, the classic antipsychotics fell into less use compared to atypicals. And in Turkey, the new generation, second generation antipsychotics and atypical antipsychotics are being used more frequently these days. In Turkey, currently, all available antipsychotics in the world are available in Turkey. In children and adolescents, this is an important subgroup. Antipsychotic medications here have a serious indication problem. When we say indication, it has to do with indications of FDA, of course. This is what we base it on, because the Ministry of Health also bases what they do on that. Risperdal, daily use is frequent. Between 5 to 16 years of age, it has restlessness related to autism. Between 10 and 17 years of age, bipolar disorders, and between 13 to 17 years of age, schizophrenia. This is the indication. In aripiprazole, in 10 to 17 years of age, acute mania or mixed episode, 13 to 17 age schizophrenia. Apart from these, they have no indication whatsoever. The other antipsychotics have no place in children and adolescent psychiatry. Clinical indications of antipsychotic drugs, we all have that in our daily practice. In psychotic disorders, bipolar disorders, these are approved anyway. Autism and Tourette syndrome, aggression, severe OCD, and post-trauma stress disorder, these are additional to therapy. These are clinical indications. Clinical indications and FDA approval, even though this is the case, and extreme groups, 0 to 5 years of age. Again, this is something from America. As you can see, in ADHD, atypical antipsychotics are being used very frequently by the specialists. Same rates are equally valid for aripiprazole. And ADHD ranks first, even though it has no indication. For instance, bipolar disorder, psychosis, where it is indicated, it is prescribed a lot more frequently in the case of ADHD, and this is a 0 to 5 year age group, very extreme group. In our field, this is not approved. This is totally out of scope of indication, but still there's widespread use. In the USA, antipsychotic medication use in children is generally not approved, and this is the same for all psychiatric medications approximately. Lithium, again, in adolescents, and valproate in adolescents. It's approved for bipolar disorder. Apart from that, mood stabilizers can also be used. Unapproved use is mostly the major factor of standard clinical treatment on evidence-based treatment applications as well. These medications are frequently used in an unapproved manner. In childhood age, unapproved use is quite widespread. 80% of all treatments include unapproved medications and treatments. Atypic and atypic neuroleptics. Atypics are more superior, more tolerable, more effective in more symptoms. Less cognitive side effects emerge, more effective in the prevention of relapses, a higher quality of life, and higher patient compliance. In child psychiatry particularly, the findings of extrapyramidal system, there are less findings. This is the biggest advantage. When we say extrapyramidal side effects, I'd like to review them. Akathisia, restlessness, not being able to sit still, stepping, irritability, dystonia, pseudoparkinsonism, Rabbit syndrome, Pisa syndrome, and the tardive dyskinesia that we're familiar with. In children and adolescents, is there increased risk for EPS side effects in children and adolescents? The answer to this is yes. With age, Parkinson-related side effects and dystonia are closely related. In children and adolescents, these side effects are more frequent and more severe. Whereas in akathisia and tardive dyskinesia, after adolescence, towards the adult age, these go up a bit, but before that, there's less of a risk. EPS, increased risk for EPS, psychotic disorder. A couple of recent studies, I'll be summarizing those. For psychotic disorders between 8 to 19 years of age, 8-week efficacy comparison trial has been performed, as can be seen here as well. Unapproved medications have been studied. Olanzapine and risperidone are equally effective, more effective compared to haloperidol, whereas EPS side effects are 85% in haloperidol, and something else more striking, risperidone, which is atypical, this is 87%, in olanzapine, this is 75%. In these children, anticholinergic medication use for EPS is 67% in haloperidol group, 50% in risperidone group, and 56% in olanzapine group. These are anti-Parkinsonian medications that need to be used. In adults, same study, adult version, in haloperidol 76%, in olanzapine 37%, in risperidone 57%. Can be mentioned. As can be seen, with regard to side effect, children are under higher risk. Antipsychotic use, even if it's atypic, does time have an effect on EPS side effects? This study published in 2004. 60 children who used for less than 60 days and 66 children who used for longer than 12 months. These children and adolescents are compared. EPS 13%, 25%, akathisia 1.7% to 3%. As you can see, akathisia is very low. Also tardive dyskinesia 5% to 21.2%. Here tardive dyskinesia is a bit higher, and the researchers have shown that psychotic diseases of childhood age medication washout period has been made very short. So tardive dyskinesia is something seen in older patients as a side effect. There's a review trial, Corral, and I knew he was going to be here in this Congress. Compared to children, adults are under tardive dyskinesia risk, only one-fold more than children. Akathisia. Now, with regard to akathisia, 3 separate studies. Again, these are recent studies. In 2007, 302 childhood schizophrenia between 13 to 17 years of age. I can teach you 5% in placebo, aripiprazole 10 milligram per day, 5%, aripiprazole 30 milligram per day, 11.8%. These are the observation rates. Similar figures in bipolar disorder. Second important side effect is its effect on the endocrinological system, because children have not completed their sexual developments as individuals. On the other hand, they're struggling against their diseases. They have to complete their development. Hyperprolactinemia can have an effect. This is what researchers are focusing on, because hyperprolactinemia related to neuroleptic use is more frequent in children and adolescents. Children and adolescents who are growing up are impacted more with regard to side effect. Another important point is, especially in pre-adolescent children, clinical findings of hyperprolactinemia is very difficult to determine. So even if there is side effect, sometimes it cannot be observed, so we have to be more careful. This is a warning. Clozapine, KTFine, and aripiprazole have an effect on serum prolactin levels. These are children's studies. Risperidone causes a permanent elevation, comes down to normal levels after it's withdrawn, whereas in girls it never goes down to normal levels because adolescence follows. In olanzapine and ziprasidone, they have a temporary elevation effect on serum levels. Potential side effects of hyperprolactinemia, amenorrhea and irregular menstrual cycles, galactorrhea, gynecomastia, sexual dysfunction, reduced libido, osteoporosis, breast cancer. This is not verified yet. A lab study, they say, may cause breast cancer. Pituitary tumors, pituitary tumors, not yet verified though, and adolescence and sexual development. Does it influence that process? There's one single study which has not been able to verify this because there are few patients. Prolactins are high either because of long-term treatment, so therefore the outcomes of the study have not put forth a very pronounced difference, but at least theoretically it's an important point. Bone loss is not something we know much about in children. There are some publications which say they cause spontaneous bone fractures. If there's amenorrhea, there is bone loss. If not, no bone loss. The main reason is said to be estrogen shortage. As we know, hyperprolactinemia suppresses the release hormone, and estrogen levels in blood decrease. Depending to that, there is resorption in the bone, meaning it's an iatrogenic osteoporosis. There's one trial that examined this, but it seems like a very important topic, especially gynecomastia in pre-adolescent children. We cannot observe clinical findings. There's no galactorrhea. If there are boys, there's amenorrhea. Here, a 9.5-year-old boy, risperidone used for later gynecomastia. So, at 13 years of age, they had to perform mastectomy in the USA. Pharmaceutical companies. Vera Sharrow, a public health activist, said this topic has not been discussed enough. She's a problem for pharmaceutical companies. In children and adolescents, hyperprolactinemia is an important topic, and sexual functions and reproductive functions should be observed very carefully because of it. Again, in children and adolescents, another important point is the effects of atypical antipsychotics on wakefulness. In long-term use, academic status and psychosocial interaction may be impacted negatively. Somnolence may emerge. social interaction gets reduced, especially imagine a sick child. Reduced social interaction is a very important loss. Apart from quetiapine, this is dose dependent because quetiapine 300 milligram, when you go above it, alpha-2 agonistic effect emerges. Alpha-2 agonistic effect, as we know, is important in academic failure or attention deficit. This is an effect that we desire. It's when you go above it, there's less cognitive suppression. This is 3 double-blind placebo-controlled studies showing somnolence frequency. Aminopropyl, risperidone, and olanzapine. Aminopropyl is more tolerable compared to the others with regard to somnolence. This is the summary of those 3 studies. Again, a related situation: sedation, long half-life period plus strong antihistaminic activity causes sedation, clozapine, olanzapine, quetiapine, risperidone, and then the newest generation, ziprasidone, aripiprazole, decreases like that. The main foundation of resistance against this medication, the most important topic in society, is obesity. May cause obesity in children. First of all, obesity in children is an important health risk independent of the medication. Studies show it's an important public health problem. For children, we should not say obese, but maybe say overweight. Overweight children, over time, they have increased over time and in a very fast manner. I have some slides. Between 1963 and 1970, this rate was 5%. Later on, it has gone up to 11% here. This includes the forthcoming times as well. As you can see, both in small children, boys and girls, and in older children, boys and girls, the approximate ratio in the year 2000 went up to 16%. The rate in 2008 is 25%. 1 out of every 4 children is overweight. At the same time, psychiatric diseases independent of treatment may have an effect on weight. Schizophrenic people are overweight 4 times more than the general population. Bipolar children, 58% of them are more overweight. Long-term follow-up trial, healthy controls yellow, childhood onset schizophrenia red. When you look at the long-term graphics, there's serious weight gain in patients we can see. With regard to medication-related obesity, children are under higher risk. Same diagnosis, children and adults. When they're treated with the same medication, they have compared all of them between 8 to 12 years of age, children, adolescents, and adults. 5.5 kilograms as a result of risperidone treatment. That's what they have gained. Whereas children and adolescents have gained 8 kilograms on the average. And when you consider the differences in weight, 8 kilograms for a child, it is 1/5 of a child, maybe 1/10 of an adult. So it's very serious weight gain potential, the atypical medications. Now, again, a recent 2007 trial, not too many trials examining this in children and adults. In pediatric schizophrenia, 6-week follow-up studies show that 7% and more weight gain is important in 6 weeks. The 7% or more gain in aripiprazole group, even at 30 milligrams, there's a 5% too. 5.2% increase in the risperidone groups. It's 15-16%. Even risperidone 1-3 milligrams, the 15% group has gained more than 7% weight. Also in olanzapine as we know, it's the most dangerous one. 45.8% of the people have gained 7% or more weight at the end of 6 weeks. Similar graphic for bipolar children, equally applicable. Melissa Del Bello, and I think she's seen on the conference as well. In her study, quetiapine came out to have less of a side effect, but in our practice it shows that that's not the case. Atypical medications compared to typicals were a bit more safe. Atypical related weight gain, the most important organic side effect, of course, there, but more importantly, the psychiatric effects, especially adolescent girls, medication-related weight gain becomes a more important problem than the disease itself. What impacts this? Females, low BMI, young age, which means low BMI people gain more weight. The fat ones gain less weight with those medications. Being young, smaller children gain more weight. Dosage, time, diagnosis, it has to do with ethnicity as well. Blacks gain more weight. Generally at the outset of the treatment, that's when the weight gain happens. Then there's a plateau stage, and the bad thing is that the more you benefit from the treatment, the more you gain weight. So dietitians and endocrinologists should come into play here. We should be collaborating with them. I just want to say as an anecdote, in America, about oral antidiabetics and topiramate, they have developed a standard treatment, especially with medications with high weight gain potential. They start working with these people at the outset. About weight gain, of course, there's another serious side effect, a disrupted glucose mechanism. Between 1997 and 2003, admission because of diabetes in New York State increased by 200%. Between similar periods, antipsychotic use in girls by 11.7%, in boys 71%. Again, diabetes medication 59% in girls, 14% in boys. That's the rate of increase in diabetes type 2 medication. 177% and 33% are the figures. The most dangerous medication is, I'm finishing, the most dangerous medication is clozapine, again olanzapine later on. Other medications are similar in the general population. Okay, I have gone over my time, so that's why I'm now concluding. I'm thanking you. Thanks.